So I want to just talk quickly about immunogenicity, which I think many of us don't think has a lot of clinical consequences, and in fact that's probably true, but there are times when we should be thinking about it, and we know that our Crohn's colleagues have started to think about it very seriously and use it in their regular monitoring. So we do know that many pathways influence the bioavailability of biologics, and immunogenicity is part of the picture, but not the complete picture. We also know that tests for anti-drug antibodies, or ADABs, only capture a fraction of the truth. Now, the assays have become more and more sensitive and specific, and they are better at detecting it in the presence of circulating drug. However, there are still a lot of issues around the accuracy of these assays. All biologics and TNF inhibitors I'm going to use as an example are immunogenic. How does methotrexate impact their bioavailability? And this is also true of the other antiproliferatives, so leflunomide, mycophenolate mofetil, and azathioprine. And finally, immunogenicity and treatment survival. So many factors can impact the clearance, and among them is cellular uptake, because we know that's how these biologics are broken down. They're also broken down through metabolism proteolysis. We have the FcRn, or the Bram-Bell receptor, which actually protects IgG by recirculating it or salvaging it, and that's particularly true as we made progressively more human monoclonal antibodies. Their half-lives went up dramatically to be much more consistent with our own IgGs, and that's due to the Bram-Bell receptor salvage. And the fact that when they bind to a target, it can be nearly irreversible binding. And then, of course, we know that there's also interaction with the Fc receptors through the Fc portion of the monoclonal, and this also determines half-life. Low albumin, so protein-losing enteropathy, as we talked about in Crohn's disease, can also increase the clearance of these monoclonals dramatically. We know that there's weight-based changes in clearance mechanisms, and there is a theory, at least, although it's not clearly shown, that high levels of baseline TNF may influence their clearances. I'll come back to the antiproliferatives, which actually prolong the half-life because they reduce the Fc gamma receptor-mediated clearance mechanisms, although we do not know how exactly that occurs. And finally, it really does depend on how humanized these products are, whether they're giving IV, sub-Q, or IM. And finally, anti-drug antibodies also are related to, of course, the product itself. So immunogenicity is related also to the disease. So a rheumatoid arthritis patient is going to make more anti-drug antibodies than an ankylosing spondylitis patient or a SPA patient. Do I know why? I don't. I do know that psoriatic arthritis patients tend to have similar anti-drug antibody profiles to RA. Again, I can't explain to you why the difference is. We think some of it has to do with the underlying inflammation and disease severity. We do know there's product-related effects. There's certainly patient-related effects because a lot of this is variable from patient to patient. And as I mentioned to you, treatment schedule is quite important so that sub-Q is more immunogenic than IV administration. It's certainly useful to do induction therapy, as was mentioned earlier today. And finally, you definitely want to do continuous treatment and not intermittent treatment, which is one of the issues around dose reduction. So the potential consequences of immunogenicity, I think we would say in the majority of the time there's really no effect, or there may be loss of efficacy, reduced efficacy. This may be because of accelerated drug clearance due to immune complexes of the anti-drug antibody to the monoclonal, and it may also be that neutralizing antibodies, particularly if they're made to the epitope binding region, which is true of most products, will also interfere with binding of the biologic. And finally, you do see hypersensitivity reactions. We can see them as infusion reactions, although they may also be due to lysis of cells, as occurs with rituximab and many of the other CD20s, injection site reactions, and rarely serum sickness, and that's usually related to an Fc portion anti-drug antibody. And rarely thromboembolic events have been reported. So the commercial assays are available to us now. Most of the assays that were done during development of these older products were either a bridging ELISA or an RIA, and they really don't detect antibodies well in the presence of circulating drug. Now the ECLIA, or electrochemiluminescence immunoassay, is able to detect in presence of drug to some extent, but it's better when you look at a pH shift anti-idiotype antigen binding method, which actually breaks apart the drug and the anti-drug antibody to then be able to detect ADAs. And finally, also fluid phase mobility shift can do the same type of thing. Unfortunately, the assays vary in their capacity to detect specific idiotypes and subclasses of anti-drug antibodies, and there's variability across these assays, as you imagine, and that's true for labs, trials, and of course, patients. We really don't still have established therapeutic drug levels of TNF inhibitors. There are suggestions of what are therapeutic, but there are patients who don't respond when they have those therapeutic levels, and there are patients who are responding when their therapeutic levels are actually quite low. So it's not entirely clear what the appropriate drug level is. It is better to measure drug level along with anti-drug antibodies, but again, most of the time when we can clinically monitor, we don't need to do that. The feasibility of conducting these in clinical practice is a little difficult because you want to collect the specimen at trough serum levels, and that, of course, is going to be more challenging. And as I said, with the exception of IBD, I don't think we agree that we need to use this in our clinical trial management yet. So I'm going to run through just some examples of the TNF inhibitors. We know, of course, that infliximab is chimeric and is the most immunogenic. And we do know that the anti-drug antibodies to infliximab are associated with lower serum concentrations, loss of clinical response, greater risk of infusion reactions. And actually what we also know is that because it's a murine portion of the FAB, we actually have antibodies not just to the complementarity binding region or the epitope binding region, but adjacent to it. And you get not just IgG and IgA antibodies, which are typical of anti-drug antibodies, but you'll still see persistence of IgM antibodies and IgE antibodies, which are associated with infusion reactions. So we can see here, and this is in essentially looking at infliximab, lower clinical responses when you have anti-drug antibodies, and you're going to have more non-responders from that point of view. And you'll also see that the anti-drug antibody titers tend to be higher in the non-responders. Here you can see infliximab trough concentrations correlate with mucosal healing in Crohn's disease so that you can get much higher and better healing if you in fact have higher serum infliximab concentrations, which are related, of course, to anti-drug antibody levels. Here you're looking at infusion reactions in RA and spondyloarthropathy patients, and you tend to have them in those patients who have anti-drug antibody levels that are higher. You can see here that you see lower levels in the SPA patients than you do in the RA patients, even though the scales are different. More interestingly, looking at the infliximab biosimilar made by Celltrion, and this was presented at last year's ACR, Jürgen Braun showed that in fact against either CTP13, which is the biosimilar, or infliximab, we saw less anti-drug antibody formation in the SPA patients than in the RA patients. You could see, of course, that the number of patients who had anti-drug antibodies is fairly similar between the two different therapies, which are, in fact, I think, biosimilar to each other. But in fact, you see a lot higher anti-drug antibody levels in the RA patients than the SPA patients. What about adalimumab? It was the first fully human monoclonal through phage display that it was done. It is also noted to be immunogenic, and the immunogenicity is to the epitope binding region. So these antibodies are neutralizing. They're predominantly IgG1 and 4, which is typical of anti-drug antibodies. And again, I can show you some very interesting work that's mostly been done external to AbbVie by the group, including Wolbank and others from the Netherlands. They started out with 272 consecutive RA patients treated, and they were prospectively followed, treated with adalimumab, and they looked at drug levels, anti-drug antibody levels, and they followed them over time, showing that 28% of them became anti-drug antibody positive after about 3 years. But most of this occurs within the first 28 weeks of therapy and then stabilizes. They said that only high levels of anti-drug antibodies were associated with decreased clinical responses and lower levels of drug. And they are the ones who reported the rare thromboembolic events, saying that they thought that they were related to anti-drug antibodies. But the conclusion of this group has repeatedly been that the clinical relevance of measuring these anti-drug antibodies is limited because they appear to be questionable predictive value, because sometimes they will go away, they will be transient, and at other times they don't appear to be associated with drug levels. So here's just showing you the time course of the development of anti-drug antibodies on the left-hand side, and then you can see the loss of response over time. So in fact, 38% of the anti-drug antibody positive patients versus 14% of the negative ones discontinued due to treatment failure. Most of these patients were still on methotrexate or other DMARDs, and in fact, there were lower drug levels in the anti-drug antibody positive patients. If you look at this in terms of the clinical responses, we're looking at those patients who didn't have ADABs in blue, those who had intermediate titers in purple, and those who had low titers in orange. And what you can see is that the lower clinical responses occur in those with the high titer anti-drug antibodies. But the ones with the intermediate levels, there was not such a good correlation. A similar kind of thing was found in PSA, where they looked at 103 consecutively treated patients with psoriatic arthritis. And they looked at adalimumab concentrations at the top here, according to the delta DAS 28. And you could see that in general, levels of about 5 to 8 appeared to be the most therapeutic. But you can also see that there's quite a few patients who have levels that are higher, and there are still patients who have levels that are lower that are still responding. In the second graph, you can see that over time, those who were anti-drug antibody negative had more sustained DAS 28 responses, but overall the differences are smaller. It does suggest that these are the therapeutic drug levels. They do correlate with what they've measured in RA patients, but as I said before, the correlations are not as good as they might be. Interestingly, of the 23 patients who were anti-drug antibody positive, half were on methotrexate and half were on monotherapy. So that's not quite as clear an explanation for whether we should use background therapy or not. But then if we combine these two series, 272 and 103, and we look at those who are on monotherapy, methotrexate with other DMARDs or just other DMARDs, you can see in the graph in the blue, we've got methotrexate and other DMARDs, and those give you the best drug concentrations of adalimumab. When you get to other DMARDs, which may not mean antiproliferatives, include sulfasalazine, the levels are more intermediate. When you get to monotherapy, the levels are lower. But what's interesting here is that when you look down below in the red, in the RA patients, 20% who were on background therapy became ADAB or anti-drug antibody positive versus 55% on monotherapy. And overall, in the smaller series of the PSA patients, it was 15% versus 69%. So it does argue for use of background therapy, even though we have a lot of questions about the efficacy of methotrexate in psoriatic arthritis. We do also know that leflunomide has an effect in psoriasis and could be an effective background therapy, but I'll come back to that. So this was the data in spondyloarthropathy patients, and essentially here we're not looking at patients who get background therapy, and yet we have much lower anti-drug antibody positivity, as was seen also with the Celltrion biosimilar and Remicade itself. So if we look at trough levels and induction regimens in Crohn's disease, which has been much more important, there does appear to be a considerable overlap of serum concentrations at all time points, and it's really not possible to say that there's a certain serum level of adalimumab that discriminates between remission status. However, we did find out that in patients who had the higher dose induction regimen, 160 and then 80 milligrams, were half as likely to move to weekly therapy over 12 months in a US specialty pharmacy study. And so like the data we have from J-Rapid and Hikari, induction regimens do appear to be helpful. And this is the data you saw earlier from Jack and Artie, and the point being that the immunogenicity is considerably higher than we know with certolizumab pegol, but this was an external assay performed in Japan, so we really can't compare it directly, but we can certainly see that the immunogenicity is less with a loading dose than without a loading dose. Regular maintenance therapy is clearly much better than intermittent treatment, and our Crohn's colleagues learned that, and they learned the importance of background therapy. Even golimumab, which is fully human, is associated with anti-drug antibodies and some low or even detectable trough serum drug levels and lower clinical responses. Here's similar data, again, from the same group in the Netherlands, 37 RA patients treated consecutively, and you can see, again, those patients who have higher drug levels have much better responses in white than those with low drug levels in black. So etanercept is still immunogenic, even though the epitope binding region doesn't appear to be the portion that elicits anti-drug antibodies, and that's because the linker portion is the part that's immunogenic. It doesn't allow changes, conformational changes, and so therefore there's less binding to the TNF, and in fact, typically etanercept binds one and maybe two of the TNF trimers and not all three. We understand about this immunogenicity because a predecessor to etanercept was lenercept, which was the P55 soluble receptor, and it's been extensively published, the immunogenicity of this product, and that was because in the end it was discontinued from development by Roche because it was immunogenic and not superior to methotrexate. So in fact, we can sometimes see serum sickness due to antibodies to the FC portion, and that's because of epitope spreading from the linker. Nonetheless, we do see clinical responses are lower in those patients who have anti-drug antibodies on etanercept, and again, etanercept concentrations predict responses. And most of these antibodies that I've talked to you about are neutralizing, with the exception of some of them to infliximab. So what about the effect of methotrexate and the other anti-proliferatives? Well, as I mentioned to you, they have two effects. Being anti-proliferative, they decrease antibody responses by decreasing B-cell responses, and they also prolong the half-life, which will act to decrease immunogenicity. This is a very nice meta-analysis that proves that point. As I mentioned to you before, you can use low doses of these products. So the Concerto trial would have argued that maybe 10 or 20 was better than 5 or 2.5 milligrams, but in fact that was in patients who started both therapies together, and so both therapies are going to contribute to clinical effects. When you look at patients who'd already been on methotrexate and had stable polyglutamate levels, and then were re-randomized to lower or higher doses, what we find out is that clinically there was no difference in ACR 70, synovial vascularity or HAC improvement between 7.5 and 20, and thus on those patients who are starting a biologic and still on methotrexate, they will probably get good benefit with as low as 7.5 milligrams of methotrexate, and in fact they'll do well with 10 of leflunomide, 50 of azathioprine, or even 500 of mycophenolate mofetil. The switching studies are simply to say to you that if somebody's developed anti-drug antibodies to one, they're more likely to develop it to a second biologic or a third, but they're not cross-reactive. And again, like we know in RA, most of our non-responders do not have anti-drug antibodies. In long-term registries in Europe, we have comparable retention rates between adalimumab and etanercept, and less so for infliximab in RA. The opposite is true in Crohn's disease. And this is just a nice little drawing to show you where the immunogenic portions of these different molecules are, and that is that if they are soluble receptor or fusion proteins, the linker portion is immunogenic. If they're monoclonal antibodies, then it's going to be the epitope binding region, unless they're pegylated with a very immunogenic PEG. That's not true for certolizumab pegol, but it is true for pegloticase. So, thank you very much. All biologic products are immunogenic, and I've used the TNFs as an example, and there are differences between them. Assays for immunogenicity and drug levels are variable. Induction regimens are helpful. Intermittent therapy is not helpful. Background therapy is definitely beneficial for treatment survival. Yet we still have a lot of non-responders for whom we can't find evidence of immunogenicity. And even when we start to see loss of response, the idea that you can dose intensify or add methotrexate or background therapy, then it's too late. And finally, the standard of care in rheumatology is based on assessment of disease activity, function, and markers of disease progression, which are much easier for us than in our Crohn's patients. So we now understand why GI practice in Crohn's and ulcerative colitis includes induction regimens, background therapy, and routine monitoring of anti-drug antibodies as well as drug levels. But in rheumatology clinical practice to date, it looks like we can still do it by monitoring how our patients are doing. Thank you.